Good evening, everyone, and welcome to BioVanguard CellTalk presentation. For today's presentation, Lenford is a presenter, and he will be discussing on the topic health-related quality of life of COVID-19 survivors treated in intensive care unit, prospective observational study. Before starting the actual presentation, let me introduce Lenford. Lenford holds a Master's of Arts in Human Rights, Governance and Development, as well as a Master's degree in Social Work and Community Development from the University of Zambia. He is currently pursuing a PhD in Developmental Studies. Through this fellowship, he aspires to acquire advanced scientific and research skills that will enhance his knowledge base, ultimately enabling him to contribute to high impact scholarly publications. Now, I warmly welcome Lenford to start his presentation.
Thank you so much, and apologies for the network challenges. My topic of presentation today is based on health-related quality of health of COVID-19 survivors treated in intensive care unit. Prospective. This is a prospective observational study. To begin with, introduction. Health-related quality of health is a multi-dimensional concept that uses patient-reported outcome measures to assess patients' physical, psychological, and social functioning. So, in a nutshell, what we are looking at, the symptoms that patients that were being admitted in the intensive care unit who were being treated for severe COVID-19 disease. And based on the symptoms that they were presenting, this is where this study was basing its analysis on how these symptoms were actually trying to affect the health of the people. So in December 2019, a new group of coronavirus called SARS-CoV-2 was discovered in Wuhan, China, in Hubei. This virus caused a large number of pneumonia-like in the population of Wuhan, and affected quite a number of people, and especially like countries like ours in Zambia. We came to know about COVID-19 as being able to affect a number of people somewhere like in 2020. So COVID-19 range from the symptoms, they range from mild to severe, with some patients reporting persistent health issues which were affecting their physical, mental, and cognitive well-being. There have been long-term effects regarding the treatment that was being given to that were admitted in the intensive care unit, and these long-term effects are capable of impacting the health of the people that were being treated for COVID-19. So this study aimed to examine health-related quality of life in the survivors of COVID-19 patients, and the associated factors which were linking the quality of life of the patients that were being treated in ICU. And in 2020 March, because of its the surge of cases that were reported in terms of COVID-19, the World Health Organization declared the outbreak as a public health emergency and of international concern. And a lot of studies, they started doing a lot of studies in order to find a cure for COVID-19. And by August 2022, COVID-19 had infected about 580 million people and caused 6.4 million deaths. And the symptoms were mainly asymptomatic and leading to severe illnesses which required hospitalization and intensive care. So as knowledge continued, in order to try and find the cure or treatment for COVID-19, And this came to light as a result of the mortality rates that were recorded. And many patients reported having experienced persistent symptoms which were affecting physical, mental, and cognitive health, which actually impacted their health-related quality of life. So this study's objective was primarily to investigate health-related quality of health among severe COVID-19 survivors who were admitted and treated in ICU. And the secondary objective was to examine factors which were associated with the worse health-related quality of life scores. So this study was a single center cohort study, and most of the population that was being studied were patients that were hospitalized in a tertiary hospital center due to severe COVID-19 disease. And among the population that was being studied, a total number of 288 COVID-19 patients were admitted in ICU, and the analysis was based on these numbers that were admitted in ICU. And all the survivors, in terms of data collection, data was collected via phone calls, as you may be aware that it was there were a lot of restrictions in order to not to contract the virus. So most governments and countries had their own restriction measures. So in trying to collect data, they devised, they employed actually the way of phone calls to examine the health-related quality of life. And this study period was in November 2021 to February 2022. And for most of the patients that were admitted in these in intensive care unit, this was a confirmatory test of a positive PCR test that was used in order to test the patients before admission. So data was analyzed using descriptive statistics with median and interquartile range, which reported for continuous data, and Mann-Whitney U-test and chi-square tests were used for group comparison, and a significant threshold of a p-value of less than 0.05 to signify the impact and significance of the data was considered. And it also employed a software named GraphPad Prism version 9.0, that is Windows. So as you may be aware, it's critical to collect data without ethical approval. So this study, the scholars in this study, they considered the ethical considerations, and their study was approved by the University Hospital Split Ethics Committee, and they were given the number approval of to go ahead to conduct the study. And informed consent was obtained via phone, as earlier alluded to, that there were a lot of restrictions in order to meet and mingle with other people who are suspected to have contracted the virus. So 288 patients who were treated in ICU, where this was the overall population that was being studied. But at the first follow-up, the study indicated that 126 patients had died at the first follow-up, which was 4 months, and about 162 patients were eligible. So amongst this number, the number that was being analyzed as the final analysis for this study, despite the 17 patients that had no contact value, and this posed a challenge to the researchers to gather the information. These were 17 patients, and 16 patients had no data on survival that was available. So about 129 patients were contacted, all in total, and 16 patients did not respond giving us a total number of 113 patients who were included for the final analysis of which this study was based. And coming to the results in terms of demographic and intensive care unit stay. So this study looked at the average age of the participants who were 61 plus years, and preferably most of them, about 74% were male, and median ICU stay was 11 days. That is interquartile range between 8 to 14. And the median duration of patients who were put on ventilatory support was 7 days. Also, the median length hospital stay was about 18 days, representing the interquartile range of 14 to 26, of which 71% had reported severe ARDs and only 2% were mild. So the quality of life EQ5D 5L results. This was a questionnaire that was devised in order to gather data on the patients who were being treated in ICU. And on mobility issues, about 29% had reported moderate or severe problems. And some of them had reported that due to the stay that they had spent in the hospitals, they were unable to walk. And on the usual activities, they had reported that about 24% were unable to perform daily tasks, and much of them leading to severe difficulties as well. And about 36% also reported the conditions of depressions and anxiety as a result of them being admitted in ICU, and 10% reported extreme problems with regards to the quality of life. So on the ongoing follow-up in terms of symptoms, it was reported that 34% had no symptoms at all, and 14% still required some oxygen support due to some conditions that they were being subjected to in the ICU, and 11% had neurological symptoms which resulted to muscle weaknesses and paresthesia and ataxia, etc., etc. So 8% also reported that cross-gen difficile infections. Also 5% had cardiovascular complications, and 5% also were reported bedridden because of the number of days that they stayed in the ICU, which also exacerbated their condition as patients. So factors that are affecting quality of life outcomes. So it was reported in this study that older age, or rather older adults of the age 65 years plus, they reported worse mobility and self-care, and also on usual activity scores. And it was indicated that on sex differences, in terms of gender, females reported the worst quality of life in all categories except for self-care, which was statistically significant in usual activities. And males were also in their problems where they reported worse quality of life in self-care. So it was also indicated that longer ventilation and hospital stay in ICU significantly lower the quality of life in terms of on the scores that were conducted in terms of analysis and the questionnaire that was devised. So more comorbidities, worse mobility and usual care scores was also reported, and a higher vertical visual analog scale was used, and it ranged from 0 to 100, which represented that 0 meant lowest and 100 meant highest health-related quality of life, which was actually prevalent in younger patients, those who had stayed in the hospitals for a few days. And it was reported that they had few comorbidities. ICU COVID patients. So severe COVID-19 cases that required ICU admission resulted in significant reductions in quality of life months, that was reported months after discharge. So most of the symptoms that were being reported as the outcome of the patients that were admitted in the ICU upon being discharged from the ICU. So most of the symptoms that were reported months after the discharge, and particularly these ranged from mobility, the usual activities, and the mental health, which came as a result of the number of days that they had stayed in the ICU. And older patients, particularly females and those with prolonged ICU stays had the worst outcomes on that aspect. So multiple studies have also confirmed persistent declines in the quality of life, particularly in physical and psychological health, even up to 12 months after the ICU discharge. So this was based on the number of stay in the ICU, and also being put on a period where they are being observed, and particularly within 4 months, as it was reported, they started reporting some of the challenges that they were facing. So ICU treated patients generally reported worse quality of life outcomes than those that were treated in hospital wards. So there were those that were being hospitalized, and those that were being cared in ICU patients. These ICU patients these had presented severe COVID-19 symptoms, hence the difference between the two. However, this comparison meant that those that were hospitalized had minimal quality of life outcomes than those that were admitted in ICU. So in this case, it was analyzed that prolonged invasive ventilation and longer stay in ICU or hospital stays and multiple comorbidities were also linked to worse outcomes as a result of being admitted in ICU. In conclusion, while these survival rates have improved, many survivors experienced prolonged symptoms and reduced quality of life for months after ICU admission. And like I mentioned, these were observed after the discharge of these patients in ICU and hospitals. So it is suggested that longer mechanical ventilation, ICU stay, and hospitalization led to poorer quality of life in all domains of admissions. So much of the discussions that have been made, this study also reported some of the limitations, and it was highlighted that this study was a single center cohort or study, and the findings of this study might limit generalization because the data was just limited to a single region. So it was also noted that no control group for comparison with non-COVID patients, and the patients were heterogeneous, and that limited follow-up period was also limited in order to make assumptions that would make us generalize the findings to other studies. So also a telephone-based data collection was also another limitation, which may be less face-to-face interview, taking cognizant of the fact that there were a lot of restrictions. Hence, the telephone was the most applicable way to collect data to these patients who were presenting symptoms of COVID-19. So, however, the limitation is that these findings, because we are using a phone to collect data, So they are presented to be unreliable as opposed to having primary data that you can collect face to face with the patients. So thank you so much, and this has been my presentation.
Thank you, Lenford. Thank you for the presentation. Audience, now the floor is
Thank you so
open.
much.
If you have any queries, so you can type in the chat box. So I don't see any questions. So this is the end of the presentation. This will be the end of the presentation. And I thank Lenford for the presentation. Thank you everyone for attending the session, and I hope to see you again in the next session.